good morning or good evening to everyone. It depends on where you are in the world. Our webinar is really international. So welcome to this new Fujita Alumni Association webinar. Today we have two speakers as usual, Professor Krishnakumar and Dr. Tamara Hughes. They will talk about very interesting topics, but before starting, let me welcome our mentor, Professor Yoko Kato, and also my co-moderator, Professor Ishu Bishnoi. And I also want to welcome Professor Ashish Kumar, who is our commentator, as usual. Unfortunately, Dr. Hari Kiran cannot be with us today for emergent surgery, but I want also to introduce our discussants today, Dr. 𝒍𝒐𝒻, Dr. Mohira Jalolova, and Dr. Heba Azuz. They will all help us in the discussion after the talks. So before starting, I would like to ask Professor Yoko Kato to say some introductory words, please, Professor.
Hi, everyone. Thank you very much for joining today. So the 1 month has passed very quickly. So this time is the June time. So I think that we all looking for your lecture. Thank you very much.
Thank you, Professor. And I kindly ask Professor Ishu Bishnoi to introduce our first speaker.
Thank you, dear Alberto. So I would like to invite Professor Krishnakumar for his presentation. Currently, he is working as assistant professor at Sri Chitra Institute of Medical Sciences, Trivandrum, Kerala. And he has special interest in functional neurosurgery, minimal access neurosurgery, CV junction surgeries, and neuro-oncology. And he has been member of various societies and published more than 10 papers. And his ongoing projects are about anaplastic astrocytoma, intracerebral hematoma trials, and experimental trial for dural substitute. Today, he will be talking on topic of functional neurosurgery, that is surgical management of functional movement disorders, technical aspects. So I would like to invite our first speaker to present his presentation. Please, Professor.
Thank you, Dr. Bishnoi. And it is a real privilege to address this August audience through this webinar hosted by Fujita Health University. Thank you so much, so that we can discuss some of the work done by my institute in the field of movement disorders, and of course, young neurosurgeons who would like to take up this subspecialty, what holds in store for them, because technology is moving at a fast pace, and it is almost like our mobile phones or laptops. You buy one and in the next. Is my screen visible to?
Yes, Professor.
Can I proceed?
Yeah, please.
Thank you. Thank you. So technology moves at a very fast pace, and to catch with it, we need to know what is happening all around and adjust the fast-moving technological advances to your workplace, that we cannot copy all of them, maybe due to technical constraints, cost constraints, etc. So quickly moving to the management per se of movement disorders. In the early 50s, the lesioning procedures were the procedures of choice. And I'm sure Professor Mathuria and the elderly senior audience in this webinar would be recollecting their experiences when patients used to undergo pyridotomy and thalamotomy in the early 50s and 60s. And then came the era of pharmacotherapy, which held good for some years. And then the pharmacotherapy related adverse effects started mounting, and there used to be situations where pharmacotherapy became unsuitable. So then came the stimulation. Actually, it was something like a serendipitous event which happened in a lab and then converted to thalamic stimulation in a human being in a trial setting, and then it became a standard of care. It still continues a standard of care. Whereas I think if FHU is holding a seminar or a webinar on related to movement disorders, I think the next era would be that of stem cell therapy. And it is growing, the scenario is growing at a very fast pace. So if we take into the requirements for which you need to set up a movement disorder surgical division, you should have adequate patient care facilities, imaging facilities. It is essential that you have some experience with surgical planning using a planning station, which may be starting off with planning biopsies, maybe a thalamic tumor biopsy, a deep-seated tumor for biopsy. Previously, it used to be stereotactic frames, but the scenario is now changing. I will come to the advances in that, where advanced targeting. There are some stringent operating room requirements. And I would consider that movement disorder surgery is teamwork. It is not a one-man show. It is definitely teamwork. When we come to the disease spectrum per se, again, it is expanding. Previously, in my institute also, it was almost exclusively confined to Parkinson's disease and some selected cases of dystonia. But now if you see the literature worldwide, the caseload worldwide, essential tremor has become one of the commonest indications for surgically amenable movement disorders. Of course, the other syndromes like Tourette syndrome, chorea, and some post-traumatic movement disorders. So this is the cross-sectional anatomy which you all must be brushing through when we learn the deep nuclei of the brain. And as this time stands now, we are slowly moving towards other indications for the stimulation surgeries, leave alone movement disorder cell. So how does it work? The stimulation per se, it is most likely it is depolarization, okay, and the surrounding spread of stimulation with the axons having a lower. So when the subthalamic nucleus starts firing, the stimulation from the electrode will suppress it in the form of a depolarization blockade. And of course, there will be resultant changes in the glutamate GABA pathways also. So there are some advantages as well as disadvantages when you consider stimulation over the older treatments. So advantages is that you can perform a very smooth surgical procedure without much morbidity, and it is reversible. Suppose you have something like a small adverse event, okay, you can switch over to the contact. There will be 4 contacts at least for the stimulation electrode, so you can go through the other electrode or vice versa. It is the modulation part of it is the beauty of it. And very infrequently only side effects creep up once you are steady with the system. And of course, all said and done, it is a bilateral procedure. Whereas the cost and the very effect that you have a functioning implant inside, like a cardiac pacemaker, you need to give care for it. It's always a foreign body inside, and none of these procedures don't address the disease progression. Disease will progress at its pace. And of course, the need for future frequent adjustment visits, or they have to come for programming often. This has also been changed. I will come to that in a little while. So movement disorder surgery, there is always a workflow. You have to follow a workflow. In the workflow, it will be patient selection first. You do a routine pre-surgical checks. You do a pre-operative MRI. Then you fuse the MRI images and choose your target, plan it well, of course, including the trajectory. Then on the day of surgery, perform a CT scan or an O-arm spin and do a frame registration. So this is the stereotactic CT or stereotactic image, which is fused onto the non-stereotactic MRI. This will give you the coordinates in space, whereas where the X stands for the laterality, the Y stands for the anteroposterior aspect with respect to the mid-anterior mid-commissural point, the point between the two commissures, and Z will will give you the height or the depth. Then in our OR, we routinely perform something called microelectrode recording, where we insert the test electrodes and we do the microelectrode recording. So as you know, as the electrode descends in a serial fashion, we always start 1 centimeter above our radiological target. And once the electrode descends, the electrode will record the electrical impulses around it, and the zona inserta first, then it will become the subthalamic nucleus firing. So you are almost sure that you are passing through the subthalamic nucleus. Finally, you exit out of it and reach the substantia nigra pars reticulata. So then you stop. In the track which you got with the best microelectrode recording, by giving current, serial increments of current, and C for adverse effects as well as beneficial effects. So then you implant the DBS lead, and then always go for a post-placement imaging. Make sure that you are in the target. And then only do the programming, because you need to be 100% sure. So the index case we can select for movement disorder surgery is Parkinson's disease, so which is the commonest indication in our setup in India. And usually it is advanced idiopathic Parkinson's disease which you select. And these patients should have excellent response to levodopa. Unlike epilepsy surgery, where the patient is worn out of the drug and multiple drugs don't give good effects, then you choose epilepsy surgery. This is the reverse here. They should have excellent response to levodopa with no cognitive impairment. That is also very important. If they have a psychiatric disease, it should be very well controlled. And those are the good candidates for. Whereas for tremor, those who have disabling extremity tremor, they are the best candidates for DBS, and resting and distal postural tremor. Whereas proximal postural tremor, they are okay, but they are suboptimal DBS. And will intention tremor respond to DBS? It will benefit to a lesser degree. And head and neck tremor, actually these are the most disabling ones, but these are actually difficult to treat with a deep brain stimulation. Coming to the targets, actually these are very standard targets that we choose, and as you can see, the subthalamic nucleus and the globus pallidus are the two main targets where we go about when movement disorder surgical treatment is concerned. Thalamus is the chosen target. The ventro-intermediary nucleus is the chosen target for tremors. So the subthalamic nucleus, see, it is not a rounded structure at all. It is obliquely oriented in all the axes. So to target it, actually it is divided into 3 parts. The most part is the mode of the controlling the limbic functions, and then comes the associative STN, and at the posterior part, the postero-medial part, you have the motor STN, which is your target. And the size-wise, subthalamic nucleus per se is maximum 5 mm to 7 mm. So you can imagine how small the target is when you are doing, compared to a 3 centimeter tumor, which you are taking biopsy using the stereotactic frame or other neural navigation or related methods. So the subthalamic nucleus, our area of interest within the subthalamic nucleus is the motor STN. Whereas in the GPI, it is the posterior 1/3 of the globus pallidus internus, which is the suitable target for globus pallidus internus targeting. And the structure which comes very close to it is the optic tract. So one has to be very much aware of the optic tract, and we stay in our institute, our policy is to stay at least 2 millimeters above the optic. So this is how we target the globus pallidus interna, and as you can see in the figure, the area 4, which is depicted as the posterior medial part of the GPI, that is the area of. So the indications for DBS applications, for STN, it is definitely that is a choice for Parkinson's disease, but nowadays we are doing a good share of GPI DBS also for subthalamic nucleus target and Parkinson's disease. So likewise, we have definite indications for essential tremor, where we target the VIM, as well as dystonia, especially primary dystonia, which is the group of dystonias of choice for deep brain stimulation. So once the patient is already admitted to the hospital, one should take care that there should be ideally a dedicated room. Why? Because even after surgery, we need to prevent cross infections, and the care given to the patient should not be altered. So there should be resources for counseling and education. For imaging, personally, I don't find any big difference between a 1.5 Tesla MRI versus a 3 Tesla MRI. Our institute has both. We have planned our images in both the MRI machines, depending on the availability of the machine, because it's a very busy institute and the MRI is always occupied. But there is no restriction that you should own a higher Tesla MRI for better visualization. Even a 1.5 Tesla MRI will do it. And always have the option of advanced sequences like inversion recovery and diffusion tensor imaging, which I will be coming to. And the option for image acquisition, this is the first step where you are going to image the patient and plan your target and trajectory. Be very sure that there is no image distortion. If the patient, due to his, because these patients are undergoing surgery for movement disorder, so at rest also, while lying down in the MRI console, they will have severe movements. And if this has an implication in the imaging, your radiographer reports that there are movement artifacts, never accept that image, go for an MRI under sedation or under general anesthesia as per discretion. And so dedicated technologists will always help you. The time schedule, that is when they are in the drug on state, you may prefer for some early on or deep off when they are not moving at all. So drug dosage guidelines also affect imaging. So you have to be very, some patients we never take in the morning, we take in the afternoon, because afternoon their drug dosage reaches a peak level so that they are in the on state. So it is very easy to take the image. The familiarization with whichever software you are handling with is very important, because suddenly if you are using a software which you are not familiar with, there can be errors. So it is always nice to have, if you acquire a software, plan some biopsies. You do some targeting, trajectory planning for biopsies before embarking on movement disorder surgery, and attending enough workshops and educational platforms. And I think this platform where we are now participating is well known for its educational platforms. So such, and always seek the advice of mentors. Coming to stereotactic, very essential part of the surgery, even now in thus performing surgery for movement disorders. So I always think that it is better that you should own your own frame, because a frame which is rendered and which travels all around the country may have its own inherent faults, which you may not know, and it may be. And of course, execution of biopsies using frame is a first. And the proximity to the imaging station is also very important while you are fixing the frame. Better to do frame fixation in the area where imaging station is there. So the shifting of the patient is not very problematic. In our institute, we do it in the portable CT, which is adjacent to the OR. So the movement of the patient is not a big issue, but it may be an issue in some institutions. So there are some frameless options which we will discuss. So as technology has evolved, many centers are now going frameless. So whether it is frameless or stereotactic frame, there should not be any tilt in the imaging which is acquired by the software, so that there is no tilt, pitch, or yaw. So if you can go for a 4-pin or a 3-pin fixation, and the time factor, the tremor factor, the torticolic factor. So you should be ready to fix frame in a torticolic tremorless patient. Okay. And always have a resuscitation station standby, because during this itself, the patient can have certain adverse reactions. And the outer table haptics. So I think most of the neurosurgeons are familiar with the outer table haptics when they do the pinning using the Fujita frame or the fixation of the head using a Mayfield. So you should be always in the safe zone and never have a misguided haptic so that you enter into the dip. So when we come to the operating room, it should be an electrically silent OR, because you are using microelectrode recording and macrostim. Microelectrode recording gets severely affected when there's electrical noise. And of course, the OR team should be ready with all the adjuncts. Like, you should not be, the patient is most of the centers do awake DBS. So the patient, without taking any drug in the morning, is awake on the table, on frame, head fixed. So one should not be hunting around for things like drill, fibrin glue, etc. It should be ready. And there should be a cross-table fluoroscopy readily available. Could be a C-arm, an O-arm, or an IC. And infection can be very deleterious. So optimization of space is also very important. And your anesthetist should be nearby so that any urgent intervention by them, or imaging, or even surgical intervention, you should be. So this is the augmented workflow. As I told earlier, it's in a nutshell. This is the augmented workflow. And one should be very familiar with what we are going to implant, like the implantable pulse generator we are using, what is the nature of the extension cable, what is the nature of the DBS electrode per se, how many contacts are there which goes into the STN, everything should be known. Because several companies manufacture this nowadays, and everybody claims that their system is good. And the typical device, of course, there are three things to be noted. One is the lead, the extension cable, and the neurosurgery. The programmer module comes later when you do the program. So I come from the institute where the first surgery was performed in the year 2000. So next year we will be celebrating 25 years of DBS in our institute. And I joined the team in 2009, and that is my experience in this field, and we perform something like 30 DBS per. So we have a checklist that a diagnosis of idiopathic PD, positive response to levodopa therapy, absence of atypical Parkinsonian features. So we have to wait to eliminate the differential diagnosis like SMA, multiple system atrophy, or PSP. And relatively younger age is what we choose for best candidates for this. And they should have a normal cognition and very good social support, family support, and access to programming. Otherwise, it may not work well. As a surgeon, we always do pre-surgical checks, the sources of infection, that is ENT, dental, dermatological checks before surgery, and best control of coexisting diseases. And the red flags, patient should not be on anticoagulants, antiplatelets, and a good general physical examination. Preoperative MRI, as I already told, the role of sedation is very important to kill the tremor factor, and choose the right sequence, choose the best ACPC alignment plane, then only proceed. And of course, naming errors can occur because there may be similar names for two patients. So it should not get merged. It can happen in some systems which accept names as the registration method. So the medical record number is actually better than name. So you should correct it and do the planning at least 2 to 3 days prior to DBS, because you may find surprises. Like we found that one patient had a very large basilar sitting there right next to our target. So we the treatment of that first than DBS. Target plan, fusion-related errors, be very careful. Usually do direct targeting, but there is a problem with distortion errors and ex-vacuum errors. So as you can see, these are the basic steps. I hope the video is playing well. Zoom display or
Yes, yes.
yeah. So once the frame is fixed, the patient goes to the CT scanner. This is the CT scan acquired with the fiducials in situ. You can calculate and this is the image fusion that we do with the frame. So image fusion, one has to be very stringent on image fusion. Do not allow for any flaws. And if you find that the automatic merge is not satisfactory, go for a manual merge. There's no problem. And this is how the OR looks like with the awake patient, the surgeon standing behind, and the neurophysiology and the movement disorder neurology team standing in front of the patient. And the frame is in situ. I always put the electrode carrier and mark my burr hole rather than going for the frame base alone. And this is the microelectrode recording going on. As you can see, of the 4 channels of recording, 3 have actually yielded very good STN firing, and the central electrode, which you see in green, and the anterior electrode, which you see in white, has gained the max. So now this was some time earlier. Now we go for least number of testing electrodes as possible. So the standard is now 2 central and 1 more electrode of choice. Physiological testing always gives you more confidence that you are in the right place and there is beneficial effects. More important, there are no adverse effects. So physiological tech. So you should have a very good neurology team with you, neurophysiology testing to be done. Post placement, you can either go for MRI or CT before the placement of the IPG or afterwards. In our institute, we implant the IPG and then we go for MRI on 2 days later, because there may be some, as you can see in the early CT scan, there is always some air trap in the frontal region due to the CSF loss, most likely. Even if we use fibrin glue during the lead insertion, some CSF loss occurs. And it is checked with the pre-operative images. Always follow the antibiotic policy of your hospital, stringent checks, periodic audit. And if you have multiple hospital affiliations, be sure that you don't entrust these to others. You have to do your own check. So now we come to the technical part of it. That is the topic of discussion for today. So far, we have been only discussing about the general aspects. So let us see what are the technical aspects. So my impression after this much from 2009 onwards, the impression which I have is that never believe the machine, believe in your senses, your haptics, and your 3D imagination of the. So in the pre-surgical MRI, never allow any image distortion error. Go for a better image of choice, then only do the plan. When you are fusing the image, you are blindly believing the machine. There can be image fusion errors. So if you suspect an image fusion error, you have 2 choices. One, repeat the image because you are doing it 2 to 3 days prior to the surgery. There's no problem. And if image fusion error persists, then you go for a manual fusion rather than automatic fusion. You should not give it altogether to the software. The ACPC line, the surgeon defines the ACPC line. So if the image is distorted, you may plot the anterior commissure as something else. So always keep that in mind. And frame fixation and the fiducial registration, of course, the frame, you need to repeated use, it may get small bends will appear, especially on the hood that you place with the radiological markers, the headset. So if that is damaged, then you will get fiducial registration. Keep that in mind. If it is not accepted by the machine as successful frame fixation, undo the frame and redo it. Then again, image fusion errors can occur after frame fixation and your image, the stereotactic image when it is fused with the pre-surgical M. So during surgery, brain shift is the big villain. Like if you are successfully done the left side, when you go to the right side, your target would have shifted because during the surgery on the left side, a lot of CSF would have egressed. So volumetric errors. What do you do for that? Mostly you can use fibrin glue so that during your entire surgery, except when you introduce the electrodes, there is no CSF. The array tubes are actually the tubes through which you introduce the electrodes. And if they are bent by any chance, you may be thinking that you are reaching the target, but the bent array tube, it will lead your electrode to some other. So there is a localization. And frame related play on a tremulous patient. The frame has some play, that is the screws are loose. If the head is totally tremulous on table, the frame will be tilted. So there will be accuracy related issues. So during cross-table fluoroscopy also, there can be image distortion. Keep that in mind. Actually, you be the judge rather than the software. And post-placement MRI also be very skeptical. Suppose your lead is misplaced, you have some clinical effects by which you can predict. Without an imaging itself, you know that you are not in the right place. So these are the lead locations, can be posterior, more anterior, more lateral, deep medial, deep posterior, too superior. So you will have the fibers which may get abnormally stimulated and you will get the corresponding adverse clinical effects. So we have this chart ready-made in your consulting room or in your area of work, and you always correlate with what you have. Coming to essential tremor, there is actually a dilemma as to what is diagnosis. So there is a level 1, level 2, and level 3 steps of diagnosis. And of course, when do you do surgery for this? When it is medically refractory, there is actually no time frame. So when initial diagnosis, and if there are no bothersome symptoms, they are just observed. And if there are bothersome symptoms, then they go for beta blockers, pramidone, or a combination. And some go for, of course, extremities, they go for Botox also. And if tremor continues to affect lifestyle, then you talk about DBS. So this is DBS for essential tremor. The VIM nucleus of the thalamus is your substrate. And it is a very rewarding surgery. And the DRTT, that is dentatorubral thalamic tract, is another target which is upcoming. The planning is slightly different when you come to XYZ of the STN or GPI. Why? Because you can see on the screen the Y, that is the anterior post, the Y is depicting the anterior to the mid-commissural point. It is 20% of ACPC length. It is not a fixed point. You have to deduce the 20% of ACPC. So this is surgery for essential tremor going on, and these are the recordings that you get, and then physiological testing. So the recommendation is that if it is for a unilateral tremor, this is ever changing. These are the recommendations in 2019, which came out in 2019. It is changing now because the unilateral lesioning adjuncts have come, which does not require a burr hole. So unilateral tremor, it is unilateral DBS, bilateral tremor, bilateral DBS, or unilateral DBS for the dominant one and delayed surgery for the second side. But if they are unwilling for a DBS, then you have further options that we will be coming to. So this is what has been very popular in the 60s, early 60s, and maybe 70s and 80s in our nation, India. But worldwide, ablative therapies started taking a backseat, and invasive stereotactic guided thermal controlled RF lesioning became the choice. So our center was also doing a lot of RF lesioning, that is pallidotomies and thalamotomy. But now magnetic resonance guided focused ultrasound has overtaken invasive lesioning. So most centers are now using MRGFS. And some centers, they are opting for gamma knife radiosurgery for lesion. So the choice of procedures for lesion, if it is dystonia or PD, it is always pallidotomy. For essential tremor, thalamotomy. But some selected centers, they are doing subthalamotomy for PD. So MR-guided focused ultrasound, it is a good technique, but needs to be more time tested. And the only deterrent factor may be the high cost. Otherwise, the lesioning effects are almost as good as an invasive RF. And so it is an awake procedure, and the surgeon is always involved because there is a head helmet which needs to be fixed, and there is a coolant pad all around the skull. So it has selected indications now, and now unilateral thalamotomy, unilateral pallidotomy, and skull density ratio is also a significant. Gamma knife radiosurgical pallidotomy, some centers are very much for it, and results are as good as lesioning as the literature claims. But what about bilateral procedures? Can you do? So bilateral pallidotomy, it is never attempted in the single setting because of severe speech-related side effects, but it can be done spaced, 9 months to 1 year spacing, it can be done. So it's a posterolateral GPI as the same target as your, so you can see the lesioning, the image, you can see the lesioning done bilaterally. One was a year ago and the one 12 months later. And VIM nucleus is the choice, nucleus of choice for thalamotomy. What we do in our institute is not a single lesion. We identify the target and we lesion 2 mm, 4 mm, and 6 mm above also. So there will be 3 lesioning centers at least. So as indications mount up, as you can see, almost 26 indications or trials for clinical disorders have come up for surgery for using deep brain stimulation, and of which our interest will be on essential tremor, Parkinson's disease, primary dystonia, chorea, some other forms of tremor, and Tourette's. So the technical advances which have happened in the arena of the frame, many centers are now gone frameless. So one option is a custom-made frame for the patient. So this is a firm which manufactures the custom-made frame, and the cost factor is very important in this. But once the 3D images of the skull with the insertion pinpoints on 4 areas of the skull are already informed, the 3D model comes with the orientation of the electrode insertion already grooved in the frame. So this is one of the best frameless options one can have, but it is custom made for the patient. It cannot be used for another patient. And this is another one which is in the market, which is based on navigation systems, and some centers are doing DBS with this. Whereas robotic DBS is another option where the robotic arm will guide you to the insertion point. And it is not a master and slave system. The neuro robot, as you know, it's only an aiming device, and the robotic arm will come and align yourself to the burr hole, and which will align you to the trajectory automatically, and then you have to proceed by doing a burr hole and insertion. So robotic systems, they claim equal or excellent target accuracies that of the frame. When coming to the method of DBS, the technical advance which is crept in now is sleep DBS. So why do we want to do DBS in the awake state? There are 2 reasons. One is for obtaining very good microelectrode recording, because once the patient sleeps, you lose the record. Second is to test for side effects or adverse effects. But once you are very sure of your target, your image fusion, there are no play or any problems with your frame, then you're on the target. So sleep DBS, especially in GPI, which is a very big and not so difficult to target, those are the indications for deep sleep DBS, where the patient is at utmost comfort, and supposing they have disease of the spine, they cannot lie for long, and you can always verify your doing a intraoperative imaging. So this is one method which has now been very popular in most of the centers. For select patients in our center also, we are doing a sleep DBS than awake DBS. So these are the differences that you can see on the screen, and it is FDA approved, and very apprehensive patients at younger age and very old age. There's no intraoperative testing involved. It is only. What about the advances in implants? Now we have rechargeable batteries. So there are two advantages. One, the IPG size is very much reduced, so small pocket on the chest, and of course, they have reported life of up to 15 years, which is actually the beneficial period of DBS. And directional electrodes, we'll come to that now. And the complex of electrode arrays, which can be individually activated, are coming up. And closed loop stimulation has adaptive DBS already in the market. So next in the pipeline will be neurotransplantation. Centers have now started installing sural nerve. They'll harvest the sural nerve, make small bits of it, and put it in the electrode track along with the DBS electrode. So it will act as a stem cell graft. So like that, neural transplantation and restoring function will become more popular than the present day. So there is a conventional second honeymoon concept that first 5 years you don't do surgery. One reason, disease is well controlled with medication. The second reason is that you can eliminate the close mimickers like multiple system atrophy or PSP, where the disease will progress within 3 years, 4 years. You are very sure that you are not dealing with a Parkinson's disease. It is Parkinsonism due to the other diseases which does not respond to DBS at all. And after 5 years, motor fluctuations and drug-induced dyskinesias, these will affect the quality of life. So they will start taking more medications at shorter intervals. The on period reduces. And so this is the time when you do the DBS. And after 70 years, there is significant surgical risk. You may resort to a pallidotomy, either non-invasive or invasive. So the second honeymoon is actually, the first honeymoon is offered by pharmacology. Second honeymoon is offered by DBS. And it will last for at least 10 to 15 years. So is there any role for early stim? So 7 years, this is concept. In our institute, it is strictly now also 6 to 7 years, but do we need to wait that long? So early DBS, like third year of diagnosis, fourth year of diagnosis has come up. Some centers are actively doing DBS in the fourth year. And there is a role for DAT scan, whereas in DAT scan, it will very accurately show the dopamine depletion. So if it is proven to, it is one of the armamentarium where you can distinguish between a PSP and a Parkinson's disease. So in the era of DAT scan, that can be relied upon, early stim can happen. So timing of surgery will reduce to maybe third year of diagnosis or fourth year of diagnosis. And genetic, always do genetic subtyping in case of dystonia, because the DYT1 is one of the ideal candidates. Directional leads, this is the anatomy of the directional lead. Previously, we did not have this luxury of stimulating only part of the electrode. So as you can see, A, B, C, it is segmented into 3. There are more complex electrode arrays nowadays available in market. So this is the simpler version of it. You have 3 segments. You can stimulate either one of them. Suppose there are a lot of side effects. So you know that that lead is lateral. So you stimulate only B, that is the medial part of it. Then you will not get oculomotor side effects. So this is how the directional lead anatomy helps you. As it helps you for both directional as well as something called interleaved stimulation. So the contacts in the ring mode and standard directional stim via the contact. Second is the role of diffusion tensor imaging. Now it has become standard in most of the hospitals doing movement disorder surgery where this facility is available, that is DTI. So you can do a DTI mapping, and on the merge of operative MRI T2 images, you can merge the fiber tracking software refined images also, and you can see how far is the pyramidal tract from your target. So in this case, it is 1.5 mm lateral. So you know that your target is safe from pyramidal stimulation. So pyramidal tract and trajectory can be easily deduced using fiber tracking. Post-implantation, now most of the companies in the market, they have systems. So this is one of them where you can see the post-implantation where you are in the STN, all the contacts are in the STN or some are outside and some are inside. But this is a machine-derived image, and you have to have clinical judgment also along with the machine-derived images. And local field potentials in the new generation DBS electrode and the IPG system, you have LFPs available. So LFPs actually they are single or multi-unit recordings which will provide detailed information about the neuronal characteristics in the field. It is not something like the LFP which we used to do conventionally. So if you have the local field potential, sorry, the MER which you do, so the LFP recordings, so it is recording from a much larger population of the neurons. So it will help your movement disorder team to do the programming very accurately when LFP recordings are. So the LFPs may be captured at the time of DBS implant. So if you are using the alpha omega system, it is possible. Or DBS lead also, and now some companies are marketing the IPGs which are capable of using the LFP derived information for programming. What about closed loop DBS? So this is a new kid in the block. So it will sense the requirement of the patient and it will deliver optimal current from the IPG. And remote programming. So I was coming to the fact that the patient has to come for programming every time. But thanks to the pandemic, where there were several travel restrictions, so it will allow the neurotechnologists to program via the internet-based technology. So the patient need not come. They just need to go to a center with good internet connectivity, and the neurotechnologists will be able to program. Long-term care of the IPG is a big issue because however much we teach the patient or the relative to take care of the IPG and see that it is fully charged, there can be problems. The charge depletion may go unnoticed. So the present era of rechargeable IPGs because everybody knows how to charge a mobile phone. So if it is a non-rechargeable IPG and they have to every day check whether the battery has depleted or not. So the recurring expenses also of inserting another IPG in the place of the worn out. So rechargeable IPG are the IPGs of choice. Now newer targets and indications, as I told, for most of the movement disorders, there are newer targets now rather than the conventional 2 targets. And it is always better to go for some kind of research in your own field once you do more of targeting and DBS. It's always better. So this is one of the work which we have embarked upon for IPG suitable for the the people of our subcontinent, which will be economically viable also. So this is one of the classical examples where you have the bradykinesia tremor predominant patients in whom DBS is very successful, but the effects may last until the non-motor symptoms predominate. So this is the second honeymoon that he has. Whereas some will have severe freezing of gait, as you can see, they will find it very difficult to lift their foot off ground, and they will require at least 2%. So freezing of gait is actually a poor responder to DBS, but there are some exceptions, like this patient who we did DBS, and actually there is no freezing of gait now. So it has benefited the patient. And of course, predominantly distal axial symptoms. Predominant distal axial symptoms, and they usually respond very well to GPI. This is a classical DYT1 dystonia. This is the importance of genetic testing also. Very disabling. And there is some technical issue with the video. Please bear.
Yes, Professor, can you move to the conclusions, please? Because we are running out of time.
Okay. So I think I would better conclude now, because there is some technical issue with that video, that however much technology will help us, it is the clinical judgment and application of clinical knowledge with what technology offers us gives best results for surgery for movement disorders. And I thank you for your patience.
Thank you. Thank you for the wonderful presentation, Professor. So I would like to invite Dr. Ashish Kumar to please give valuable comments, and then the house is open for the discussion.
Thank you so much, Dr. Ishu. Professor Krishnakumar, I am not a very knowledgeable expert on this particular subject of deep brain stimulation, but I could actually follow through your presentation. And when I was in NIMS, NIMS was one of the Nizam Institute of Medical Sciences in Hyderabad, one of the larger centers who were doing a lot of deep brain stimulation procedures, and few of my colleagues are still continuing that program. So I could see, and I was actually able to participate in some of the DBS procedures early on in my career. Here in Toronto, actually, as you said in your slides, MRI guided focused ultrasound is a big thing now, and almost for lesioning, they're I think my colleague, his name is Dr. Lipsman, and he is doing almost like 2 or 3 MRI guided focused ultrasound procedures for essential tremors, essentially. So there is a very well set program. As you said, it's a teamwork, and there are a lot of academics and research involved in the focused ultrasound program. We are also, I think, participating in psychosurgery in psychiatric disorders, like, as you mentioned, PTSD is one of the indications. And at other sites in Toronto, there is obviously more work in Parkinson's and essential tremors and dystonia. So, I mean, if there is someone who is interested in young neurosurgeons in the group, or whosoever is watching, we have a program where focused ultrasound is actually a big, big thing, and it is one of the few North American centers who have established this program, and they are doing very well, actually. Almost 2 to 3 cases a month of focused ultrasound surgeries are being performed. So excellent talk. Thank you so much. I'll just say, like, in terms of vision for the future, what do you think is coming up in DBS overall, nationally or internationally? I know that psychosurgery is one part, but anything else which is on the horizons coming up in the future?
Deep brain stimulation for epilepsy is, I think it will become very popular. Already VNS is there, vagal nerve stimulation already exists, but deep brain stimulation for epilepsy and the fast pace with which Alzheimer's is catching up in the form of diagnosis as well as treatment algorithms. I think in Toronto also, Professor Lozano is actively doing anterior commissure or APS, anterior perforated substance, anterior commissure DBS for early Alzheimer's, whether it can stall the progression. So Alzheimer's and epilepsy, I would think, will have a lead role in DBS, whereas for Parkinson's, it may shift more to focused ultrasound as well as stem cell.
And focused ultrasound, because I was talking to one of my colleagues back in India. How far in India it is? When do you expect that this will be a part, apart from the financial constraints? But I think for national institutes,
as of I know, till this time, only one center does it. For last 1.5 years, a center has been doing it. Some of our patients have gone there and got a lesioning done. It is extremely costly. It is almost costly or more costly than a bilateral DBS. The cost factor is very significant, and we do not have that much. Another center is coming up in another metro city. So we need to have collated. So it is useful. It is advantageous, especially of late diagnosis and patients already on aspirin, clopidogrel. We cannot wean them off, and severe cardiac issues or other organ related diseases, kidney or liver. So those are very good candidates for that.
Thank you so much.
Yeah, Dr. Ben.
Yes, thank you so much for your very comprehensive lecture. So I want to further elaborate on Professor Kumar's question. So for the indication of the DBS, so further indication could include DBS on vegetative stage and also Alzheimer's disease. So what is your opinion toward these two indications? And also, concerning the thalamic, the VIM target, what's your opinions toward the bilateral targeting in the same section? Would you consider it in your center? Thank you so much.
DBS for Alzheimer's, the trials are already on. And as I mentioned, Toronto is one of them who are actively pursuing it. And regarding persistent vegetative state, not sure of the clinical implications or the usefulness. I'm not quite sure of it, but Alzheimer's definitely, and the anterior commissure is the chosen target, and what trials are going on. It is still not in the approval stage. And when you consider VIM targeting, if it is for, as I mentioned, it is for tremor, and if the problem with essential tremor is that once in the early stages, it is almost always unilateral. And that is what drives the patient for lesioning procedures rather than a permanent implant in the body. But bilateral deep brain stimulation is the method of choice. We would always advocate bilateral VIM implant DBS surgery, because at some point of time, the disease is going to be bilateral. So don't wait for another implant. Whereas for lesioning, we would wait at least for 9 months or up to 1 year. Then we do lesioning on the opposite.
Thank you. Thank you so much.
Dr. Hugh.
Hello. Thank you for the interesting lecture. I have 2 questions for Professor Krishnakumar. In your institute, is the neurosurgeon the person who interpret the physiological recording, or you need neurophysiologists to be with you in the OR?
It varies from center to center. In my institute, it is actually a teamwork. So the movement disorder neurologist comes into the operating room, and it is a movement disorder neurologist who interprets the microelectrode recording and does the physiological test. It has been the pattern since 2000, year 2000. Whereas in some centers, the neurotechnologist alone comes, and if in doubt, the microelectrode recording images are transmitted to the console of the neurologist who may be sitting in their chamber, and they will try to interpret. But there are some centers where the neurosurgery team themselves will do the microelectrode recording interpretation as well as microstim testing. So it varies, but whichever is comfortable with your work pattern, I think better to go for it. In my center, it is the movement disorder neurologist.
Yeah, thank you very much.
Dr. Opara?
Thank you so much. Prof, thank you for your very lucid lecture. I enjoyed every minute of it. And it made me to start thinking about the possibility of training in functional neurosurgery for my people back home in my country, Nigeria. I just want to find out how long will it take for a neurosurgeon to further train or subspecialize in functional neurosurgery, please?
It depends on the infrastructure the neurosurgeon has in his operating room. So if the operating room is equipped with a stereotactic planning software like neuronavigation, most of the neuronavigation machines will have a stereotactic planning software. You should have facility for clock-stable fluoroscopy and a very silent operating room where no electrical interference at all. And the team which will select, which will help you in patient selection, in basic workup of the patient, as well as the post-implantation program. So these are the basic requirements for your team. And as a neurosurgeon per se, I would say if you are comfortable in planning and executing at least 10 to 20 thalamic biopsies, you are in for planning for a movement disorders. Because the target is very small, so you should target larger lesions like a thalamic tumor, a thalamic gliomas. They are easy to target. Then you go for targeting small targets like STN or G.
Okay, thank you. What I really wanted to find out is how long does the training for it take? So if, for instance, I want to send a neurosurgeon to your center, which I think is a high volume center for training, how long will it take? A year, 2 years, a few months? How long does it take to train?
The training program we offer is for a year, and it is a post neurosurgery degree program, at least a year of experiences. So our functional neurosurgery postdoctoral fellowship is for 1 year. It's a 1 year program. We consider at least 1 year training is essential.
Thank you so much.
Yeah, Dr. Michael.
Okay. Which one is better, GPI or subthalamic nucleus stimulation device? And do you use both of them simultaneously in same patients? And my second question is there a place for cerebellar nucleus device like dentate nucleus and the like in movement disorder?
For classical Parkinson's disease with the triad of bradykinesia, rigidity, and tremor, and if the bradykinesia is predominant, we still consider subthalamic nucleus as our choice. There is no going back on it. But if it is a tremor predominant and severe motor fluctuations are present throughout his on-off state, the GPI is a better target, but the drug requirement after DBS won't wear off that fast like STN. You need to take some more some more dosage of drugs. Is not easily weanable from drugs. Whereas if you do STN DBS, you can easily wean them off the anti-Parkinson medication. So I consider STN as the better choice to GPI. But in some situations, even if we get very good microelectrode recording, we are sure that we are within the ST. The pyramidal tract will be very close to it and severe adverse effects will come. In those patients, I have converted on table to a GPI, or on a different sitting, I have done GPI DBS to them and they have improved well. The patients have improved well. I do not have personal experience of implanting STN on one side and GPI on the other side. That I don't know. But there are reports of all four combinations, like both GPI, both STN, one GPI, one STN, or two GPI, one STN. All combinations, case reports have come. Regarding the dentate nucleus stimulation, it is mostly lesioning which has been tried, the dentate nucleus, that is age-old. In my country, the Madras Neurological Institute was doing a lot of dentate nucleus cerebellar ablation procedures, but for DBS, not much of indicational choices.
Thank you, Prof.
So I asked Dr. Samjo to give some. Okay, yeah, please, Dr.
Thank you, Prof. Thanks, Prof. Krishna. Fantastic lecture. I would like to ask something a bit unconventional. For the patients who fail the levodopa challenge test, they don't get at least 30% improvement. Do you have any experience in which you also perform DBS for these patients and there was a good outcome after that?
For the suboptimal indications, this is one of the suboptimal indications that we have done deep brain stimulation, with the caution that their expectation of complete drug withdrawal or complete relief from drug-induced dyskinesias, that may not happen, but their activities of daily living will improve tremendously. And they will have at least a 10-year of good motor freedom. So as a suboptimal indication, we accept it, but upfront we actually discourage them from DBS.
All right, thank you. Because there are some reports where they say it's helpful. Just wondering whether it's worth trying.
Because trials are on for pedunculopontine nucleus, PPN stimulation for such patients, as well as freezing. If there is bilateral freezing, those patients are not actually good candidates for DBS. But PPN nucleus, which is pedunculopontine nucleus, which is 10 mm below the mid ACPC, that is upcoming as a target. Maybe it will become a target for suboptimal drug beneficial effect patients also. It is not upfront DBS that we offer.
Okay, thank you so much.
So are there any more questions? So Professor, please.
Excellent presentation, Krishnakumar. Say the gamma knife is much more available as compared to the deep brain stimulation, and the cost factor also. So what is the status of lesioning by gamma knife versus deep brain stimulation at present?
Sir, again, for gamma knife, the targeting subthalamic nucleus is the targeting issue is the main issue because of the close proximity of various tracts nearby. But gamma knife thalamotomy is an accepted method for tremors. It is an accepted method, gamma knife thalamotomy, but the patient screening and execution, it needs to be worked out like a program. It is cost effective. And I think your alma mater, as you know, Srijitra is also your alma mater, but Vijay Chandikar and Nimans have taken it up. And gamma knife thalamotomy is a very good option, very good cost-effective option. But problem is it can be done only unilateral. Bilateral will cause severe issues. Unilateral, symptom predominance, gamma knife is a good choice.
Thank you. Thank you.
Thank you, Professor. So if there are any more questions, so if there are no questions, we can proceed with the next presentation. So I would like to invite Dr. Alberto to introduce the next speaker.
Thank you, Ishu. It's my pleasure to introduce the next speaker, Dr. Tamara Jus. Dr. Tamara Jus got her graduation at University of Trieste in Italy, then the degree of neurosurgery in 2010 at the University of Padova. And then she got a PhD, a degree in robotics, brain and cognitive function at the Italian Institute of Technology at the University of Genova in Italy. She is the coordinator of the neuro-oncology section of the Italian Society of Neurosurgery, and she published over 140 scientific papers in international journals. She is particularly involved in the field of neuro-oncology, and actually today she will talk about low-grade glioma surgery, myth or reality, so a very intriguing title. Please, Tamara, you can share your presentation and start. Thank you. We cannot hear you, Tamara.
Okay, do you hear me?
Yes.
Okay, sorry for the mess. Okay, so do you see my screen?
We do.
Okay, thank you so much. Thank you, Alberto, for your kind and friendly words. And I want also to renew my gratitude to you and to Professor Cato for inviting me in this international webinar. So in this presentation, I will be showing you some key points in surgery of low-grade gliomas between myth and reality. In the Greek mythology, there is a story in which a young lady gives her boyfriend a thread to find a way out from a labyrinth. And I think that as neurosurgeons nowadays we have to navigate with the technology and innovation to find our way out of the labyrinth of low-grade glioma challenges, because this type of surgery poses different challenges. Challenges in surgical planning, challenges in technology, challenges also in surgical act. We also have challenges in intraoperative neurophysiological and neurophysiological monitoring. And every day we also face, as neurosurgeon and also as neuroscientists, we face with different type of challenges, because we have also to keep in mind the high interindividual functional variability of our patients. So I use this symbolism to try to explain the labyrinth in which we have to run to find the better surgical solution with our patients with low-grade glioma. So in current literature, the role of surgery is well defined. The surgery represents the cornerstone of management of these patients. Considering the attitude of low-grade gliomas to infiltrate the subcortical pathway, in the last years, the concept of maximal safe resection has spread like a mantra in this field of clinical research and investigation. And currently, we know that the combination of direct electrical stimulation and awake surgery represent the more reliable and effective tool to maximize the resection, minimizing the risk of postoperative deficits. I think that to have overall comprehension of the role of surgery in low-grade glioma is essential to analyze, to investigate the surgical act at each evolution phases of this disease. And considering the curve of glioma evolution over time, we can analyze the role of surgery at the beginning, in the phase that is called silent, in which we have the incidental low-grade glioma, in the symptomatic phase, and then at the time of tumor recurrence. Starting from the beginning, the role of surgery in incidental low-grade glioma is debated. The class of evidence in current literature is only C, so evidences come from just opinion leader. In a past investigation at our institution, we investigate which is the effective role of surgery for incidental low-grade glioma, and we compare data from incidental low-grade glioma surgically treated with the symptomatic one. And as expected, we found that incidental are small lesion and are more sensitive when compared to symptomatic with for radical resection. But analyzing the type of distribution of this lesion, we achieve a step of knowledge more. We demonstrated that they are not only small lesion, but they have the tendency to develop at cortical level without infiltrating the subcortical pathway, and this is the reason why we can perform a radical resection. But the big question in current literature is, are there indolent lesion or not? Is better to propose to our patients wait-and-see approach or an early surgery? And to answer this question, we develop an international multi-center investigation. With this study, we collected almost 300 of cases of incidental low-grade gliomas. That is a very huge number if we consider the rarity in this clinical setting. And we demonstrated that there was a negative association between the preoperative tumoral volume and the extent of resection, and a positive association between the extent of resection achieved and overall survival, even in incidental low-grade glioma. We also analyzed the tumor recurrence, and we found in this study population that tumor recurrence was present in almost 40% of cases. That means that the incidental low-grade gliomas are not indolent lesion, and we have to consider this type of lesion as precanceral progressive tumor lesions. And focusing the attention at tumor recurrence, we also discover another important key points of discussion, because the strongest predictor for tumor recurrence was the time to surgery. This finding underline that even if we are in presence of incidental low-grade glioma, a delay in surgery may imply a selection of more aggressive foci of the tumor, so foci with a more aggressive behavior. So even if we have an incidental low-grade glioma, surgery should be recommended. The role of surgery in the setting of symptomatic low-grade gliomas is wild and strongly documented. The European Neuro-Oncological Association recommend surgery with a class of evidence of B in presence of symptomatic low-grade gliomas. And at our institution, we explored in the last 2 decades not only the role of surgery, but also the impact of the tumor growing pattern in this clinical setting. We know that low-grade gliomas may grow over time by 2 different growing patterns, the proliferant one and the infiltrative one. In the proliferant one, generally, we can notice that there is a similar volume across different tumor MRI sequences. In a proliferant growing pattern, the tumor generally displaces a regular shape with regular margins, and the subcortical pathway are generally displaced. On the other hand, when we speak about infiltrative growing pattern, the tumor volume is different across different MRI sequences. The margins are irregular, and we have, by using stratigraphy, the infiltration of subcortical pathway. As a consequence, as expected, we can suppose a radical resection in the first setting and a partial resection in the second one. But in the middle, there is the gray. And if you look at the volumetric volume, that means differences between T2 MRI and T1 MRI, we find an index able to provide a direct correlation with extent of resection, which implies a correlation with the survival and seizure outcome, because higher is the index, higher is the infiltration, and as a consequence, minor will be the extent of resection achievable. In low-grade glioma surgery, is important, it's fundamental to develop a so-called multimodal integrated intraoperative protocol, because is a demanding surgery strictly depending on innovations and technology. At our institution, we follow the technological advancements over time, and as a consequence, we changed over time our intraoperative protocol. In the first protocol, we used the classical brain mapping and the wave surgery technique. In this protocol, during surgery, there is a continuous alternation between tumor resection and direct electrical stimulation phases. The problem we have mainly with this protocol is that between two consecutive tumor resection phases, there is an information gap. In the second phase, we introduced the overlap of functional MRI data and stratigraphy on the neuronavigation system, and by changing the protocol, we recorded an increase on the extent of resection achievable. But the second protocol was not sufficient, because negative mapping is a reality. The concept of negative mapping was introduced by the UCSF group in 2008. Negative mapping does not mean the lack of function, and so as a consequence, negative mapping may influence the surgical act in positive or in negative with a non-functional negative balance. Negative mapping relies on different factors. It may depend on individual variability, mechanism of plasticity. It also be related to the not appropriate task selected for awake surgery, because we know that one task is not sufficient to investigate the target area. But it also related with the intrinsic limitation that we have with direct electrical stimulation. Direct electrical stimulation is an high spatial resolution technique, and physically is insufficient to create an imbalance in the network when we have to investigate language and extra language complex functions. So considering the negative mapping may limit the surgical act, we decided to introduce the so-called real-time neuropsychological testing. This type of testing is administered by our neuropsychologist during awake surgery, and allow to fill the information gap between two consecutive direct electrical stimulation phases. In addition, it allows to monitor how is the cognitive function monitoring during the resection at subcortical level. So in this way, real-time neuropsychological testing allow us to reduce uncertainty due to the negative mapping. And now our protocol is a combination of brain mapping and brain monitoring. With brain mapping at the beginning of surgery, we have the possibility to create a localization functional map and to investigate how are the relationship between tumor and cortex. And by using the monitoring during the surgical resection, we can obtain a continuous real-time information on the network status. And for lesion close or in the motor areas, the monitoring is provided by MIP and SIP monitoring, while for lesion in language or extra language areas, the monitoring is provided by the real-time neuropsychological testing. By shifting the protocol over time, we recorded an increase in transient deficit and a decrease in permanent deficit. And looking at the extent of resection data, we obtain, moving from the first protocol to the last one, an increase in extent of resection of 16 percentage point. So if we consider the cost of technology, if we consider the time required and the time of learning curve of the all medical staff, 16 percentage point of gain seems to be very little. But if you focus our attention on the Kaplan-Meier curve, a gain of this 16 point in percentage of extent of resection means to double the probability for our patients to be still alive 10 years after surgery, because the probability is 50% when the resection is radical, while the probability is only 25% when the resection is about 85% of the initial tumor volume. The supramarginal resection is an emerging topic. It means to extend the resection beyond the flare margins of the lesion. In our experience, it's very difficult to provide a balance between supramarginal resection and cognitive status, especially if we move in extra language cognitive complex network. We don't have nowadays intraoperative tools to define exactly eloquence during the neuropsychological monitoring, especially when we have to face with a higher interindividual variability. Maybe it's possible to obtain a balance between a supramarginal resection and cognitive status only for small lesions, and especially for lesions far from the hubs nodes, because in hubs nodes we have connections of different subcortical pathways, and nowadays we don't have a battery of neuropsychological testing to monitoring continuously and in parallel different cognitive functions. Regarding the tumor recurrence, unfortunately, even for those cases of radical resection, low-grade glioma may experience with certainty tumor recurrence with a frame time of 3 or 6 years, between 3 and 6 years. The role of surgery is poorly documented in current literature. We have just only 10 or maximum 15 papers on this topic. In our experience, the role of second surgery is effective. I mean, patients that underwent a second surgery presented a better overall survival when compared those treated with simple chemo or radiotherapy at the time of tumor recurrence. Unfortunately, once more, the key points to select a second surgery is the tumor pattern. If the tumor recurrence with a proliferative tumor pattern, that means that the tumor recurrence in a previous surgical cavity, we have a good chance to perform a second surgery in safe condition and with higher probability to achieve a good extent of resection even in a second surgical procedure. Otherwise, if the recurrence is of the tumor happens by an infiltrative pattern, it's very difficult to perform a second surgery, because the infiltration is along those white matter tracts in which we stop surgery at first surgical procedure. Anyway, we have a good chance to follow what happened from a functional point of view in patients by using the so-called long-lasting MRI follow-up, because sometimes happen that it's possible to see a functional reshape between first and second surgery. And if there is a contralateral reshape thanks to the plasticity, we have a good chance to perform a second surgery, even if we have the infiltration tumor growing pattern at the time of tumor recurrence. Unfortunately, the surgery is just a small chapter if we consider the war story of glioma evolution. And in this recent investigation, we analyzed what happened in our patients in 10 years after surgery for those cases in which it was possible to perform a radical surgery. And we found that there was the 15% of that, regardless the molecular class. Regardless the molecular class, according to the last WHO classification, and also according to the WHO, the previous one edition, sorry. This means that, unfortunately, we have a wide range of mutations that are still unknown, and that are the main driver for tumor recurrence. In this setting, I believe that the culture model in vivo, in which we can expand the low-grade glioma cell lines, is a very reliable and effective tool to investigate new molecular marker. Unfortunately, the model is very expensive and it's time-consuming, but in our experience, it offers the probability to define in a very small subset of patients a new wide range of genetics profile. And by using the mutations recorded, by using the cell line of low-grade glioma patients, we had the possibility to develop a score. Unfortunately, from a neurosurgical point of view, we find that the genetics score of our patient resulted to be the only independent predictor for survival, for malignant transformation, and for tumor recurrence, once in more, regardless the extent of resection achieved. So it's very complex to provide a general picture of low-grade glioma. Is a complex disease in which the standard statistics is not sufficient to define how our patient will be progress over time in this slow-growing disease, but continuous evolving disease. In the near future, I think that the big data models will offer us the possibility to define from a cognitive point of view, and also from a genetic point of view, the new model, the new predictive models, because the big data models allow us to investigate not only the single variable, but how the variable interacts to each other in our patients. So surgery has a central role, is a true reality in low-grade glioma patient management. A multidisciplinary team is fundamental to treat these patients, and the team is strictly dependent on technology. In the future, as a research perspective, we have to think to integrate all volumetric data, all NGS data and cognitive data in complex model to refine prognosis of our patients. Unfortunately, considering the rarity of this disease, a multi-center study has to be designed, and to develop multi-center study, we should think to define the so-called homogeneous and standardized protocol to acquire information. Recalling the initial question, low-grade glioma surgery, myth or reality? Low-grade glioma surgery is nowadays a reality in all the evolution phases of this disease. However, there are some concepts that we have to consider as a myth. Supramarginal resection, I think that is the first myth, because is feasible just only for small lesion far from the so-called hubs of connectome. Artificial intelligence model is the second myth, because has a very great potential from a research point of view, but we are very far from develop a model like that in this clinical setting, because low-grade glioma is a rare disease. And finally, the third myth is related to the plastic potential of our patient. In a single patient, it's possible to investigate over time the plastic potential of the brain, but it's very difficult to create a group analysis in this clinical setting, because there is a very high variability in terms of connectomes and distribution of functional areas. So if one day we will able to obtain data from group analysis in terms of plasticity, I think that as neurosurgeons, we also have the possibility to refine our surgical act and our surgical intraoperative strategies for each patient. But now, in the present, we have to think to tailor for each patient an individual surgical plan that is dynamic over time according to the plastic potential of each patient and according to the evolution of disease that unfortunately is debated, is prone to develop over time in a development in aggressive and in a high-grade glioma. So we have reality and myth, and I think that only developing multi-center study we can improve our knowledge in this kind of rare disease. So I thank you. I hope to be not late.
Thank you very much, Tamara, Dr. Hughes, for this very nice presentation. You made it very clear, according to you, what is real in the field of neuro-oncology and surgery for low-grade gliomas, and what is probably still kind of a dream. So I would like to open the discussion. First, I would like to ask our commentator, Ashish Kumar, to spend some words to comment Dr. Hughes' presentation.
Thank you so much, Alberto. Professor Hughes, this was an excellent presentation where I think I could follow your work in the field of low-grade gliomas from many years back, and almost a decade back. So congratulations for your work in this area. I feel like, depending upon the location, the eloquence, as you said, our maximal resection terminology differs. I was hoping to ask you that a low-grade glioma in a non-eloquent region, you will obviously go for supramarginal resection, although it's a myth, but you'll like to take out all the areas which are probably in the borderline as well. But if suppose you are dealing with an insular glioma with no mass effect and it's incidentally detected after seizures, so wanted to know, how do you approach these kind of lesions, young patients completely intact? How do you deal with them at your institution?
So thank you for the kind words and for the question. If we have a young patients with a low-grade glioma in insular region, we have an advanced protocol of MRI, and we follow data of spectroscopy and of PET MRI. If the advanced MRI data suggest a diagnosis of low-grade glioma, we propose surgery even if we have a young patient without seizure history and without deficits, because as I show you, the concordance between spectroscopy and histology is very high, and because especially in young patients, it's very important to propose early surgery to avoid risk of anaplastic transformation or microfoci of anaplastic transformation, as we demonstrated in the international investigation. So I know that is not completely accepted, this kind of approach from the scientific community, but with the investigation we performed just to improve the knowledge we have in this rare disease, we demonstrated that delay surgery, that means a surgery, the delay surgery, the definition between early and delay surgery in our investigation is a time range of 6 months. So 6 months may be sufficient to imply the development of a more aggressive foci. So we propose surgery to our patient even in this condition if advanced MRI images is indicative for low-grade glioma.
Thank you. And the second question I would like to just ask here is the role of biopsy versus early radiation and chemotherapy versus the role of upfront maximal resection, safe maximal resection. What do you consider about that? Because some of these insular gliomas, you can only see changes on the flare sequence, and actually they're not enhancing, and they have not even shifted any normal anatomical structures. So they are very early in course. So there is a school of thought about early biopsy, early tissue diagnosis, and radiation and chemo. What do you think about that?
So we don't use biopsy as option because the risk of deficit with biopsy and with surgery is almost similar. But I think that now we are going through a new era, because I think that you know that we are going to start with the international study about 𝑣𝒂𝒑𝒂𝒍 target therapy anti-EDH1, and I think that we are entering in a new era. So if the target therapy will show an effect even for patients treated with biopsy, maybe as neurosurgeons we will enter in a new era, and we should consider more biopsy than we are used to do nowadays in our clinical practice.
Thank you so much.
Thank you. I see Michael 𝒂𝒃.
Thank you, Doctor, for your nice and excellent presentation. So I have a few questions. So on your presentation and on your research, the incidental glioma recurrence rate was 38.73%. And is it because of the extent of resection or the glioma natures? And have you checked these low-grade gliomas with the WHO grade 1 and grade 2? So which one was having a high recurrence rate, grade 1 or grade 2? Is there any difference? And when they recur, how was the recurrence rate? The recurrence was the recurrence tumor. So is it low grade tumor, or where they recur to high grade gliomas? And then the last question is there any change on the recurrence if we do supramarginal resection? Have you checked in your research maybe? Thank you.
So thank you to you. Too many questions. Maybe I get follow some points, but I try to remember all points you ask me. So regarding the type of glioma we consider only glioma grade 2. According to the new WHO classification, grade 2 refers to diffuse infiltrative low-grade gliomas. That means oligodendrogliomas and astrocytoma. So we didn't include grade 1 in our analysis. Regarding the effect of supramarginal resection, personally, I don't have experience in supramarginal resection, but in this work, there was also the participation of Professor Dufaux. Professor Dufaux gave us his cases in which he was able to perform supramarginal resection, and for those cases in which the resection was supramarginal, the risk of tumor recurrence was 0, and the overall survival was 100% in the Kaplan-Meier curve. Regarding the effect of the histology on survival of our patients, we consider the survival data, stratifying the data according to the extent of resection and also according to the molecular WHO classification 2016. And we noticed that the survival and the risk of tumor recurrence was independent from the WHO classification. And regarding the last question, I think that it was about the type of recurrence. The surprising result we had is that in 30% of cases, the recurrence was not a low-grade glioma, but a glioma grade 3. And this fact underline and strengthen the consideration for which we have to look at incidental low-grade glioma not only as a benign lesion but as a precancerous lesion.
Thank you very much.
Thank you to you.
Thank you. We have our discussant, Dr. Sam Jo.
Thanks, Prof.
We cannot hear you very well. Okay, now we can hear you. Okay, perfect. Go ahead. Yeah. Go ahead.
All right. Since we are doing the low-grade glioma surgeries quite early and a lot of patients are asymptomatic, so of course I think the monitoring intraoperatively needs to be very important to avoid deficits. What about, of course, awake surgery would be the best. What about patients who are too young to undergo awake surgery or for some condition in which they are not cooperative? What are the monitoring methods you use and how do you make them as accurate as possible so then you don't get a false negative mapping and you end up taking that eloquent area? That's the first question. The second question, maybe any adjuncts you use like gliolan during the surgery which helps to identify the tumor intraoperatively? Thanks.
So thank you for these tricky questions. So regarding the first one, you are right. It's very difficult to perform this kind of surgery when the patient is not a good candidate for awake surgery. For example, for younger cases, I mean children or teenagers, or for very old patients, because low-grade glioma may also, even if it's rare, but may also be present in elderly. In these cases, we use a functional, the protocol that I called number 2. That I means the resection is guiding according to the anatomical data of the neuronavigation integrated with tractography and fMRI. It means to accept a priori to remove less tumor because we don't have a functional check. So we prefer to stop early the resection by using the data of the neuronavigation. In pediatric centers, many colleagues are developing, but unfortunately we don't have this possibility, but many colleagues are developing the functional preoperative preoperative evaluation by using, for example, the resting state fMRI. Someone believe that resting state MRI is more effective to understand the global network and to provide a functional data to use even in patients not candidated for awake surgery. Other believes then the principle of oscillations between resting state MRI is not so effective because oscillations does not mean causation. And the debate in this field, it's open. And I think once more that the new target therapy will change our approach to low-grade glioma, because if we can consider the possibility to have residual tumor important, for example, because we can't perform awake surgery, after the surgical procedure, we will have a new weapon to treat our patients. So once more, we will change a new scenario in the next 2 or 3 years. And regarding the gliolan, I use the gliolan in the setting of low-grade glioma, especially when the preoperative advanced MRI give the probability of FHU of malignant transformation. But it's very difficult to follow the fluorescence by using the gliolan in the setting of low-grade glioma.
Okay, wonderful answer. Thank you.
Thank you to you.
Thank you, Dr. Tamara Use, for the presentation and also for answering the many questions during the discussion. I think we can close the discussion at this point, as I don't see any other raised hand. I want to thank both speakers, Professor Krishnakumar and Professor Use, for wonderful presentations, and also the discussants, Sanjo and Professor Kumar, Ashish, for helping with the discussion. I think we have some minutes now to introduce the new fellows of the Fujita Bantane Hospital. But before giving them some minutes to introduce themselves, I would like to just let all of you know about the advancements of our alumni association. So we are running a newsletter. The hope is to have this newsletter published 4 times a year. We are already done with the first 2 newsletters. This is also possible because of the help from Dr. Hari Kiran and other fellows. I think it's very important to share what's going on among us, and also to keep connections between us. It's very nice to see that we have a WhatsApp group where cases are published very often to ask opinion to other fellows and to other alumni. So it's another way to improve ourselves with the help of the others. So I strongly wish the current fellows to join our association once they are finished with their fellowship with Professor Yoko Kato. And I would like to ask Dr. Michael Azeget, please, to introduce yourself briefly and tell us something about yourself, your country, and your research. You have a few minutes.
Okay. Thank you. My name is Michael Azeget. I am from Ethiopia. So currently I'm doing my fellowship at Fujita University under Professor Kato's mentorship. So I have been here for the last 3 weeks. So I will be here for the next 1 month, and like 5 months are left. So in general, for 2 months. So I have been as a neurosurgeon for the last 2 years. So most of the time after graduation. So I was doing neurotraumas, pediatrics, neural tube defects, and tumor surgeries. So my institution is called Debre Berhan University. So it's around 130 kilometers out of Addis Ababa, the capital city of Ethiopia. So it's a new hospital, university hospital. So after graduation, so I've published one research and 3 case reports on the international journals, and one of them was a recent publication on the pediatrics neural tube defects case reports of cartilage and ulnar deficiency, longitudinal ulnar deficiency in lipomyelomeniingocele child, so which is a rare case report as a 𝒂𝒂𝒍 association in Journal of Neurosurgery. So one of my interests is cerebrovascular surgery. So there are a lot of cases, stroke and aneurysm in Ethiopia. So currently there is only one neurosurgeon who is doing aneurysm surgery in Ethiopia, open, and one interventional neurologist doing interventional neurosurgery in private hospital. So after my fellowship here, I think I will be able to help some of my patients back home in my country. So I would like to thank Professor Kato for supporting us and giving me the chance to observe and do my microanastomosis in the lab and train myself to help my people in Ethiopia. So for those of you, Ethiopia is located or found in Africa, so East Africa, the Horn of Africa. So the peculiar thing that Ethiopia is known for is one Ethiopian coffee, the other is Ethiopian long distance runners, and the third one is Ethiopia has never been colonized, and the last thing is Ethiopia has its own alphabets and language. So it's called, the official language is called Amharic. And Ethiopia has 13 months. So in the rest of the world, there's 12 months. So in Ethiopia, there's 13 months. So every month is 30 days, and the rest 5 or 6 days will be summed up as a month. And every 4 years, the 13 months will be 6 days. So it's called ጳጉሜ in Ethiopia. So Ethiopia has 13 months. So these are some of the few things that I want to tell about myself. So thank you for having me on this international conference. This is all.
Excellent.
Thank you, Dr. 𝑤𝒐𝒂𝒍. We wish you a long run in the field of neurosurgery in your country, of course. And we have now Dr. Huy Pham.
Oh, I presented.
Go ahead.
Yes.
I presented in the last sessions, but I can present introduce again because there are some other new fellows today as well. My name is Huy Pham. I'm from Hanoi, the capital of Vietnam. Is a country in Southeast Asia. I graduated from a residency program for 2 years ago. And I've been practicing in Hanoi. And in the same weekend that I mostly do the trauma cases. My professional interest in neurosurgery includes brain tumors. And of course, I really want to learn cerebrovascular surgeries as well, because I encounter a lot of aneurysm, rupture aneurysm in the emergency settings as well. So that's what's the reason why that I apply for the fellowship program in Fujita Health, with the support from Professor Kato. I'm grateful to her. Vietnam is a country in Southeast Asia that you maybe mostly know about Vietnam-America War, but there are a lot of interesting things to explore the countries. We also have the coffees as well. We are the fifth largest exporter of coffee in the world. And there are a lot of landscapes with long history that you are welcome to visit some days. Thank you very much.
Thank you very much, Dr. Hui. And I think there is a newcomer, right, at Fujita. I don't know his name. Maybe he can introduce himself. Yes, please introduce yourself.
I'm Dr. 𝑒𝒑𝒂𝒍 from Pakistan, and I just arrived a few minutes ago in Fujita Hospital.
We cannot hear you. You muted. Please unmute. Okay, introduce yourself now.
Can you hear me now?
Yes, now we can hear you.
Okay, I'm Dr. 𝒖𝒂𝒍 I'm from Pakistan, and I just arrived right now to this hospital, and I'm very thankful to Professor Yoko Kato, who gave us this chance to apply all the knowledge we will take from here in Pakistan, because there are some deficiencies in our country in the field of neurovascular, and I hope that I can help my people back there in Pakistan. Let's see, it is my first day in Japan. Let's hope that it goes well. I'll be here for 2 months. And Pakistan is a South Asian country. Everybody knows that, next to India. And it has a multicultural country with multiple 4 weathers. And most all types of crops are grown there. We have mountains, seas, rivers, and all of you are welcome to our country. Thank you.
Yes.
Thank you very much for your introduction, and welcome to Fujita Bantane Hospital. Good luck for your experience,
Thank you,
of course.
Thank you.
Thank you. Thank you.
And I think we can conclude this webinar. I want to thank everyone of you, especially, of course, Professor Yoko Kato, Professor Ashish Kumar, Semjo for the nice discussion, my co-moderator, dear friend, Ishu Bishnoi, our 2 speakers today, and the fellows, and also, of course, Dr. Raja and Ben and you for being in the backwards of the organization. So thank you very much to all of you. I kindly ask Professor Yoko Kato to spend a few words to conclude this session.
First of all, welcome, the Dr. Sharp. Still, I do not know his name, but welcome. So you use Japanese style, the knife also, please.
Okay.
I think at our institute is mainly vascular surgery is doing every day, but you can visit so pediatric or sometimes functional or endoscopic. So many the field, the giant is located working here around here. So maybe you can visit them. Not only the Fujita. Thank you very much. Today, Tamara and also the Krishnakumar, excellent lectures. Thank you so much. We learned a lot from both of you. And
Thank you, Professor Kato.
Yeah. So recently, I think that
Thank you.
Individual, the tailored, I think the treatment is maybe very common now. So I think it's very important. That is the neurosurgical future. Thank you very much. Thank you for everyone.
Thank you, Professor Yoko Kato, for providing all this training program to everyone from the different parts of the world and running this educational program. I really congratulate you. Arigatou gozaimasu.
どうもありがとうございました。
Thank you, Professor Kato. Thank you to all of you, and see you next time, first Sunday of every month. So see you in July.
Thank you to all.
Thank you.
Bye.
Thank you.
Goodbye.
Bye-bye. Bye.
Goodbye.
See you